Our first speaker is Dr. Ross Sullivan. Dr. Sullivan received his medical degree from SUNY Upstate Medical University, where he also trained in emergency medicine. He subsequently completed a medical toxicology fellowship, and he's also board certified in addiction medicine. He works in a number of different capacities, to include as Helio Health's medical director, as SUNY Upstate's medical director of medical toxicology, and as the director of the Upstate Emergency Medicine Opioid Bridge Clinic. It's a privilege to welcome Dr. Sullivan.
Good morning, everybody. Thank you very much for having me. It's a pleasure and honor to be here. So today, I'm just going to be setting the stage a little bit about the epidemic. I think everybody has some awareness of the epidemic, but this is just some numbers to refresh your memories, or perhaps some of you don't know. So really, I just want to kind of framework the epidemic, and I keep using the word epidemic because it really is. If you have any questions, just please ask. I'll try to get through this in a timely manner. I have no financial or personal disclosures, and I'd like to really start with this, and there's opiates and opioids and what they really look like, and what they are. And for those people who do or don't know, this is the poppy, and these things are the latex in the poppy. And this is where we get what from? This is where we get morphine from. This is where we get codeine from. We don't get heroin from this. So we take the poppy and we take the opium latex, and from that, heroin is actually made in a laboratory somewhere. And that's actually where we get the heroin from. And I always start with these pictures because this epidemic and the opioid epidemic is not new to the United States or to the Americas, right? This is something that we've been dealing with since the inception of this country and since people came over here originally. The opioids and opiates have been something that people have been using and abused from the beginning of the time in our country here. And in fact, there's quite a bit of literature that states that people who are coming over in the original ships had tinctures of opium and often used them for an array of things in addition to even abusing them, but before we even thought about this problem recently. And what's interesting is that for those people who learn about, say, Thomas Jefferson, who this is, Thomas Jefferson did a great job of talking a lot about his life and documenting a lot of it. And he had all sorts of ailments, and he had gastrointestinal and rheumatologic problems. And he never really felt good until he started using something called laudanum, which was basically a tincture of opium. It was a pain medication. And he writes to his friend one day, and it's not really showing up here, and he says that he only felt in his habitual normal state when he was using laudanum. And he says that basically the only thing that makes him feel good, that gets him through the day, is using this opioid or opium. So this is something that we can even see today, hundreds of years later, being translated to today. Sometime after that, we had the introduction of opium dens in the United States. These started cropping up in the West Coast and even somewhat on the East Coast. And we had a large amount of people who were becoming addicted to actually smoking opium. And this is in the 1840s, 50s, and 60s. And what we start seeing at this time are some laws that restrict opium, but really it was anti-immigration laws that started around the same time to really restrict the movement of opium into the country, as it was known to becoming a burgeoning kind of epidemic in the United States, even at that time. And now we started seeing it into the introduction of pharmaceuticals, right? And so in the 1870s and 80s and 90s, we start seeing the pharmaceutical trend of using these opiates in medications. And one of the more popular ones was Mrs. Winslow soothing syrup, believe it or not. And this was something that was used for children. And it was used for when they were teething or when they were colicky. And it wasn't just sometimes just on the teeth. Sometimes it was actually promoted to be drinking a little bit. So we're starting to see this being used more and more in society and starting to be introduced as being a medication which has a lot of indications. And of course, people in this room have probably taken paregoric, right, which is an opium. We start seeing these things being advertised. We start seeing something cube morphine or sulfate of morphine being sold. And this was an advertisement in the American Druggist around the turn of the century for cube morphine to help all your ailments and your stomach aches and your joint problems. But I think it's important to see, you really don't know where you are until you know where you've been, right? And that's why it's important to talk about these things. And in 1893, which was an amazing year in medicine because the Bayer Drug Company came out with two things, I think, that changed the landscape of medicine. And the first thing that they came up with as if it shows on. I hope the picture shows up. Aspirin. So these scientists at Bay were able to synthesize salicylic acid and aspirin, which is an amazing medication, right? We use it for a lot of things today. And around the same time, they invented heroin in 1893. And they invented heroin, why? Because they wanted to curb the addiction of morphine and opium that was in the United States at the time. This was something that you can get sent to you in the mail around the turn of the century that you could then use on yourself or bring to your physician to administer yourself the heroin. So this is not something that is brand new. This is not something that's a brand new problem. It's something that's an old problem, but we need now new solutions. Now, we're going to skip a whole bunch of time, and all kinds of stuff happened between 1940 and 1988 until today. An important thing was the Harrison Act in 1914, which basically says if you are a physician or treatment provider, you cannot prescribe an opioid to treat opioid addiction, right? And that's what the Harrison Act basically says. Now, there's a bunch of little different caveats that get passed over the years, things like methadone clinics and buprenorphine waivers. But in general, it is against the law in the United States to give an opioid for opioid addiction or withdrawal, okay, except for these certain caveats. Part of the reason why we're here today, right, is because it's not always easy to treat this problem. So from 1914 today, all kinds of different things have happened, but this is why it's important. And what really happened around 10 years ago is something that in American history is one of the most sentinel and important things that you can talk about, and that is for the first time since documentation of deaths in this country, drug overdose has surpassed all other ways of accidental deaths in the United States. It has passed car accidents and shootings and accidents and falls and so on and so forth for the first time ever. And that's why this is important, right? And what's contributing greatly to this rise of deaths from drug overdoses is the opioid epidemic. And it just so happens to coincide with the exact same time frame. Now, in 2017, estimated over 70,000 people died from overdoses. Some of these heroin, about 30,000 involved fentanyl, right? Fentanyl is a opioid, is a synthetic opioid. Now, of ages, or excuse me, years on the bottom, and you can look at different things, and unfortunately the color doesn't really work on the screen, but you can see that the line, the yellow line, the one that's the highest, about 30,000 is other synthetic narcotics other than methadone. So you can see the fentanyl causing about being solely responsible for about 28,000 deaths in the United States in 2017, with heroin closely behind at 15,000 deaths. Don't forget about some of the other things like cocaine and benzodiazepines. Those are also important. But opioids, number 1 and number 2 on the list of deaths. So about 43,000 deaths solely attributed to synthetic narcotics and heroin. Apologize for the way this looks in all these different screens here, but basically what we're showing here is that over the years, we're seeing an increase between male and female, both increasing in deaths and prevalence over the years, and you can see the rate of increase over the past 20 years, both in male and female. And what we see here is the age range. We see 45 to 54 with the dark blue line on top. This is why it's important, right? This isn't just, oh, it must be the kids, the 18, 19, 20-year-olds. It's really not. This doesn't discriminate to age. It doesn't really discriminate to ethnicity or gender. I just showed you that males and females are both increasing, over time. Here's 45 to 54 from 1999 to today, one of the largest and sharpest increases. After that is 35 to 44, so 35 to 54. Underneath that is 25. So 25 to 55. All age ranges are increasing, 25 to 64, 15 to 24. All age ranges are having an increase in deaths related to drug overdoses, believed mostly to be due to the opioid epidemic. This is a little bit of ethnicity and race information for you. As you can see, the blue line, all races, all origins, are increasing. The top line is non-Hispanic white, increasing and has the highest amount. After that, we have non-Hispanic, Black, and even in the past 3 years, there has been a sharp increase in the Hispanic group, and something that we talk about a lot when we're in the treatment world is that all of a sudden because it was kind of flat for a long time, we're starting to see it really increase in that demographic as well. A lot of these graphs you've seen before, but okay. Now, we can see here when they actually take a United States average of opioid deaths, they're able to look at different states and see if you're a little bit lower than the national average or around the same as the national average or higher than the national average. We can see here in this kind of mid-Atlantic moving into the central part of the state, we can see that quite a bit higher than the United States rate. We're apparently a little bit less in New York State compared to the United States rate. But if you were to look at this graph over time, you would see the graph overall coming from much below the rate to turning more green and then even bluer over time. Okay. This is drug treatment admissions over a decade's worth of time. These are mostly due to opioids, but there's also other synthetic drugs that are included in this data. But to also look at the epidemic, we have to see that more and more people are looking for help. More and more people are trying to get help. And we can see that over time, over the course of about 10 or 15 years, that the graph starts changing in terms of people looking for help and actually admitting themselves into inpatient detoxes and inpatients. So this is about 10, 15 years ago. This is several years after that. That's several years after that. So now it's only a few years ago. So you can see that more and more people are seeking help as the epidemic continues to wage on, that more and more people are trying to get themselves into some type of treatment of some sort. See here. And you can see even redder in the Midwest states. So when we look at New York State, we can see that the deaths of all opioids from 2010 to 2016 has increased. So the orange is 2016, the blue is 2010. We can see that death rates, overdose deaths has increased for all opioids. We can see them increase exponentially for heroin, and also other opioid pain relievers, and then synthetic opioids excluding methadone, which almost always means fentanyl. So we can see that all types of opioids have been increasing over the past 6 or 7 years in New York State. And then we'll get to some local data right now. So what we can see here is overdose deaths involving heroin per a given amount of population in New York State in 2016. And what we can actually see, there's opioid on the left and heroin on the right. And right there in Onondaga County, there we are, and we are considered to be one of the highest quartiles in the state of New York for deaths from opioids in the entire state. And if we look at kind of the central New York area, here's some county data. We are in, obviously, Onondaga County, and these are deaths per 100,000 population. And you can see that in central New York, across these 6 counties, we are at the highest in terms of deaths per 100,000 population for opioid overdose. Here's our county specifically. This is our medical examiner data. We can see from 2012 to 2016, we had a very large increase of deaths. If you look at the colors, we have not heroin or fentanyl being the blue on the top. But if you look at the red and the green, these are areas that contained fentanyl, the red heroin. And if you looked at just the purple and the red, those included both heroin in those groups. So you can really see that the majority of this is heroin and fentanyl related deaths. 2019 data, that's just the first month or two, I believe, down there. But we can see that we had a little bit of a decrease for whatever reason in 2017, but in 2018 we started moving our way back up again. And I have 2 last slides to show you before we're done, and this is why this is really important, I think, why we need to continue to look at other avenues to continue to treat. This is a very biological disease, okay? This is not a moral failing, right? This is not people just deciding to use drugs. We have a very scientific, medical reason as to why these things happen. And these are, kind of PET scans where we're looking at the dopamine receptors. And on the left, we have a control, which are people who are not drug addicted. And on the right, we have people who are drug addicted from either cocaine, methamphetamines, alcohol, or heroin, okay? In a normal basal resting person who is not drug addicted, we see that the activity of dopamine receptors is pretty high. We see the red in that area on those left, right? And that means you're having a normal amount of dopamine, which is the feel-good receptor, at a normal base level in your brain. This is the reward area, the hippocampus, the midbrain. It controls a lot of how you feel and a lot of why you do things, right? On the right are people who are drug addicted, and at a normal resting rate, you can see it's void of almost any red, right? There is less dopaminergic activity, right? And this talks a lot about tolerance and dependence and why people continue to use drugs despite the consequences, despite all the problems, despite being able to die or overdose, is to just get to a normal resting level or basal level of dopaminergic activity. I have to continue to use drugs to just have my normal brain chemistry intact, right? And that's why it's important. That's why we're here, because it is very biological. We need to continue to look at ways to treat these people, right? I didn't show a picture of a moral failing. These are MRIs and PET scans of people's brains. So it's very important that we continue to look at ways as the death rates continue to increase. And this is the last slide, and it's nothing really important, but this is why I put this slide here, because there's really a couple of things that are really important to look at. And I always ask everyone I'm in an audience, I say, how many people have ever started a diet or wanted to eat healthier? And if I ask you to raise your hands, every single person I would think would raise their hands. You don't have to do it. If I were to say to you, keep your hands up, how many people have ever cheated on that diet or failed that diet? Every single person's hand would still be up. And I would say that every single one of you relapsed. Every one of you relapsed, okay? Addiction is a chronic brain relapsing disease, a lifelong disease. And it has relapse rates like blood pressure and asthma, all right? It has similar relapse rates to other diseases that we never think twice about treating. But the difference is that when you come in with an asthma exacerbation, we can treat you with medications easily. If you come in with a high blood pressure in the emergency department, I can treat you with all kinds of things. But there's not many things that an exacerbation can kill you as easily as an opioid or opiate overdose can, right? And this is why we're here, and this is why something like we're talking about immunizations, and we're talking about all different ways that we can treat this disease, because it is so deadly. And because you can relapse on this disease up to 60% of the time, it is a very, very deadly disease that we have to face. And that's why we're here today, and that's why we're talking about some possible novel ways to treat this deadly disease. So with that, thank you very much. If there are any questions I can field before I turn it back over to Dr. Thomas? Yes, sir.
Great review, Ross. I have a question about one of your early slides.
Sure.
My question has to do with one of your early slides where you demonstrated the exponentially rising death rates. The most recent block of time was something like 16%. And then before that, it was in double digits too. But there was a little time period when it kind of leveled off to about 3%. Are there lessons we can take home from that? It was like the early 2000s or sometime around then. Is there something hidden there?
You know, it's, we think that a lot of the death rates from opioids, especially in the early 2000s, has a lot to do with the opioid pills, right? We think it has a lot to do with the prescriptions of opioids, because in reality, you know, the death from specifically just heroin has actually always been kind of high, right? The reason we're talking about it now is because fentanyl is now involved. And in the early 2000s, fentanyl wasn't a driving force at all in these deaths. In the early 2000s, it was mostly prescriptions. Formulations of prescriptions were changing at the time to make them more difficult to abuse. So a lot of these things were happening around, 2000, 2005, to 2008 or so. Does that specifically answer the question? I don't know. I think that's a little bit maybe of just what I think maybe happened. Maybe there's a little bit of a leveling off. But that's also the time that hate to say this, but people were really becoming addicted from pills. You know, we really started as a profession really overprescribing in the mid to late 1990s. So I think we saw the fallout of that after 2000. But heroin death rates have been steadily increasing, right? But the sharpest rise is the fentanyl, right? For sure. And the numbers of people using are slowly increasing since 2000. So,
Ross, great review. Thank you. You know, I think it's appropriate to focus on the death rates, as you mentioned, and that's really been what's garnering the national attention. But as you and I both know, it's just the tip of the iceberg.
Yeah.
In terms of the true burden of diseases associated with drug addiction because of all the patients who are hospitalized with endocarditis and spinal abscesses and all that. And, you know, what bothers me is when people say, well, things are getting better because the opioid death rate's declining. We both know that the hospital rates are increasing. So I wonder if you could address what the true burden of disease is and what you're seeing in the hospital and what we should be doing in the hospital to address addiction.
Well, what we know is that admissions to hospitals, emergency departments have been increasing. They've increased here. We know that the burden's in the billions of dollars in terms of economic. But what happens is as treatment becomes more readily available, other treatment options, we're seeing a leveling off of people maybe dying. But that's not because, like Dr. Undy's saying, it's not that less people are probably using, right? There's been a percentage of users killed off already, number one. And then through huge programs with methadone or Suboxone or Narcan programs, the death rates have decreased. But that is right, that is just death, which is the most common denominator that we're all here to try to save, right? That's the most common life denominator is life or death. But the true burden is huge, right? And what we're seeing are a lot of these people now are becoming hospitalized. They maybe are being saved in the field, but they're coming into hospitals, right? And the hospitals, unfortunately, sometimes are the worst place for these people to go because they're not treated appropriately or they're not given the right medications or they're not given the right resources. So I always advocate that we treat this disease like every other disease, and diabetes is a perfect example. I wouldn't admit you and not give you your insulin because you're eating a bunch of cakes and pies, right? I would give you your medicine, I would educate you, and I would make sure you were linked to treatment after you left the hospital. This disease is no different. But again, this disease needs so much more put to it. We can't just have one or two medications for this. This is a true epidemic, and we need to keep pushing forward with talks like this, to continue to bring the death rate down, but also the total burden and other people suffering from this disease, because it is much larger than just death rates, and you're absolutely correct. Is there anything else? Great. Thank you very much for your time. I appreciate it.